Good morning. Is the team of round table is available now? Please, yes, you can come. Today, our round table will be on the hearing screening, not only neonatal hearing screening, for hearing screening in all age groups. Hearing loss is an important and pervasive concern and affects life of many individuals at all age group. And neonatal hearing screening will not discover all cases of hearing loss, because in the postnatal period, in children, in adults, in old age, all will have reasons for affection of hearing. A risk of hearing loss increase with age. And if in adult, it will be about 13% among age of 40 to 49, it can reach to 90% among people's aged 80 or more. Early detection and timely intervention affect the life of children and affect also the emotional and mental and cognitive well-being of adults. Hearing loss can happen suddenly, but the decline is usually gradual. So, since it passes unnoticed, it takes longer time for the seeking advice for the hearing loss. So, a key factor is the early intervention as soon as possible. That's why hearing screening is important in all age groups. So, who should be screened? Children with kids, of course, neonates and children in the school age, people with any medical the indication for affecting the hearing, adults above 50, people with family history of hearing loss, and people with noise exposure and above 60 years of age. So we have to discuss these points, and today our round table will include our professionals here, Professor Manuel Manrique. Sorry for the name if I can't say it. Professor Ebtessam, Professor Hala Omari, Professor Farid, and Professor Suela. Huh? Sallavaci. And for me after that. Okay? Please, Dr. Manuel.
Thank you very much for the introduction. So my talk is going to be split in two parts. So I am going to speak first about newborn screening using genetic tools, and at the end I am going to speak about genetic screening or screening in adult patients. So this is the experience we have in a protocol we use in Europe in collaboration with 3 countries, Portugal, France, and Spain. And we try to implement the use of genetic screening in the newborn hearing screening programs due to the high prevalence of cause of genetic diseases in this population. So in our country, it's about 60–80% of cases of newborn hearing losses due to the genetic screening. So the idea is why to implement genetic tools during the auditory screening programs. This is the algorithm we have in our country. So we try to do the screening between 0 and 1 month of age of children, the diagnosis between 1 and 6 months, and the treatment at the age of 6 months. So introduce genetic tools, decrease positive and false negative cases, reduce in-patient follow-up, also reduce rate of children referred to diagnosis, provides etiological diagnosis, accelerates diagnosis and early treatment, at the end, facilitates a personalized medicines in the treatment of the disease. So all these algorithms reduce expenses in general. So this is more or less the algorithm we have with the genetic screening. We implement that when we have, after 1 month of follow-up, the first data that this child has a permanent hearing losses. And we use a gene panel for that allows to have, in prospective way, to have 50% of detection of genetic causes of these hearing losses. So this accelerates the program because reduce the tests we have during the second visit. Yes, during the second visit. So we reduce a lot of tests in this moment. Also, it's very important in syndromic cases because we address the attention in these periods to the specialists that are related with the phenotype of this gene mutation, and reduce genetic diagnosis delays in syndromic manifestation, and reduce expenses for unnecessary visit in medical specialists. And also delays, avoid delays in the diagnosis process. We have information from the beginning, just 1 month later on, about the screening. Well, we move. Just a few words about that. The idea is to have in our hospitals not only hearing screening programs, also introduce genetic in this area. Hearing screening in adults. So some questions about hearing and balance in elderly population. So we have a problem that high prevalence, low visibility, and high impacts in the quality of life of these patients. So prevalence of chronic diseases, older people than 60 are arthritis, high blood pressure, and in the third position is hearing loss. So it's a very prevalence in our population. Also, it's very invisible disability, and has a high impact in the quality of life, not only about the effects of communications on even over other non-auditory effects like cognition, depression, dependence, loneliness, and at the end decrease the quality of life of these people. So we are speaking about hearing loss treatment in elderly patients. We have to implement 3 parts: the primary prevention, secondary prevention, and also tertiary prevention. Primary prevention means prevent disease or injury before it ever occurs. And it's necessary to add in the midlife of the persons, so between about 40, 50 years of age. We know that there are some factors that are influencing in the onset of hearing loss, like gender, age, noise exposure, smoking, cardiovascular diseases, diabetes, inflammation, genes, obesity. So we need to correct these risk factors just to avoid that hearing loss appear or minimize the effects of the hearing loss in the early population. The secondary prevention is to reduce the impact of disease or injury that is already occurred. This done by detecting and treating disease or injury as soon as possible. So at least in my country, there is a big lag between the hearing loss onset and the start of the treatment. And this is the sentence that people usually say. So I manage this situation. My friends abandon the hearing aids, cochlear implant. For me, I am older. I don't want stigmas for what we you have to hear, and etc., and etc. So in our population, the delay between the onset of the hearing loss and the start of treatment is about 12 years. So it's too much, because during that time, our brain is changing. So a hearing loss at the end produces a problem about the cognitions. So we demonstrate that there is a strong correlation between hearing loss and cognitions. So our proposal is just to start the screening programs in elderly people in the family doctor, even auto self-tests, using very easy materials like questionnaires, HHIS or SSQ-12, or even just to test a pure tonal geometry in 4 kilohertz that can be implemented in some applications. And if don't pass, has some hearing loss, move to the next step to the audiologist and ENT. Tertiary prevention is to soften the impact of ongoing illness or injury that has lasting effects. So we know today hearing loss, cochlear implants, communication systems are a brain candy for the brain of our elderly people. So this is our very fast talk. So I try just to concentrate on the 2 main ideas that we are doing is genetic screening programs plus hearing screening programs, and also implement screening programs in early population. Thank you very much for your attention.
Thank you, Professor. Now, Dr. Ebtessam.
السلام عليكم. طبعا فرصه سعيده ان انا في المؤتمر النهارده. ان شاء الله نتكلم على application of hearing screening program and its implications on early intervention process. Here actually this is a message about the link between screening in general and the early intervention, the concept of early intervention. Screening in general is a process of applying to a large number of individuals certain rapid and simple measurements to identify those individuals with high probability of disorder in the function tested. As the professor said, we have the 3 levels of prevention strategies: primary prevention, secondary prevention, and tertiary prevention. Screening lies in the secondary prevention territory of progression of a disease to a fatal or unwanted outcome. Hearing loss, why hearing loss? Hearing loss has high incidence, 1.5 to 6 infants per 1,000 live births. Can be properly managed, and sequelae of it can be softly reduced. Hidden anomaly, it won't appear unless the child is at the age of language. So previously we were able to do this screening counting on the joint committee of infant hearing على high risk registry, which were the family history of hearing loss, congenital infections, craniofacial anomalies, very low birth weight, hyperbilirubinemia, ototoxic medications, bacterial meningitis, low Apgar scores, mechanical ventilation syndrome associated with congenital hearing, and the other risk factors were admission to the intensive care unit, premature births, respiratory distress syndrome, and intracranial hemorrhages. However, this selective screening of the high risk registry would have missed about 50% of cases. So we went to the universal hearing screening, which is a screening of all neonates in the well baby nursery. Autoacoustic emission is the test of choice recorded. Usually it takes less than 1 minute, can be achieved without audiological expertise. When dealing with autoacoustic emission, you have to know that the sensitivity of it is between 85 and 100%, and reasonably specific between 91 and 95%. So it can distinguish between true negative, true positive, and they can judge who is the baby who needs further investigations. About the universal newborn hearing screening program, we have the two-stage approach. The first stage, within the first 48 hours of life, 1 or 2-step autoacoustic emission testing or combined autoacoustic emission with automated ABR in the high-risk infant registry. Children who fail in the hospital screening test are referred for a repeat testing between 2 and 8 weeks after discharge. The second stage is the diagnostic ABR testing to validate the positive second stage results, and it should be by the 3rd month of age. All infants identified with hearing loss should receive appropriate early intervention very soon after the final diagnosis, which would be by the 3 months of age and definitely before the age of 6 months. Here comes again the high-risk registry. If the child passed the screening in the first screening program, if it was within the high-risk registry, follow-up is recommended for this child even after hearing screening program is over for him. Note that the Joint Committee on Infant Hearing recommends that each country should adopt the most important rule to create its own protocol according to the regional administrative possibilities, the governmental decisions, and its budget. The problem here in the screening, 2 problems. The first one, deceased children pass screening, which is not possible with autoacoustic emission, as I think. The second problem, our normal children fail screening, and this may happen. The late onset deafness, which is linked to the children with high risk registry. So if we did the high risk registry and kept those children for regular or scheduled follow up, we won't miss those category of patients. Successful and cost-effective neonatal hearing screening program should detect all infants with permanent hearing impairment as early as possible with high sensitivity. Infants without permanent hearing impairment should pass screening with high specificity, low referral rates from screening, and low loss to follow infants. Loss to follow is a term describing those infants who lost to follow up during the screening program. This is the schedule of newborn hearing screening, which is screening step 1. Screen, who pass will pass, who fail will go to the next, again transient evoked autoacoustic emission. Who pass will pass, and who will be referred to go to the screening step 2, and finally for the diagnosis. Take home message: early intervention means early. Early means early. No way for appointments or far appointments for children for the diagnosis step. A strict surveillance procedure and closing the circuit is important for accurate statistical purposes. Counseling is an important issue in dealing with screening results. Here comes the skill of breaking bad news ability for the doctor to introduce this information to the family. A good, caring, and reassured family. This is the family who would be enclosed in the interventional program effectively. Thank you.
Thanks, Professor Ebtessam. Now, Dr. Hala Omari.
Hello, thank you everyone, and I appreciate being here to present the study that I have performed with my colleague. And it's an interesting session where we are talking about the hearing screening in general population. So usually when we're talking about hearing screening, we are targeting infants, but young adults also are at risk, especially with the, okay. So young adults are at risk, especially now with the advancement of technology and with the use of the listening, their personal listening devices. Okay. So this study has been published in the Journal of Multidisciplinary Healthcare, and I would like to extend my appreciation for my colleagues who contributed in this study. So basically, when we are talking about young adults, based on the statistics of the World Health Organization, around 1.1 billion people aged between 12 and 35 years are at risk of hearing loss due to noise exposure, and this is mainly due to recreational settings. The Centers of Disease Control and Prevention also states that 5 in 10 young people listen to music or other audio devices too loudly, and 4 in 10 are exposed to dangerously loud sounds, such as concerts and sports and gaming. So we have a vast number of studies that have investigated the effect of personal listening devices on the hearing of young adults. And I will talk about them quickly. So basically, studies are showing that the incidence can reach up to 23% among adolescents and young adults. It seems to be that there is the belief of young adults that they are immune to hearing loss. So they don't believe that listening to their devices at an extended range can cause harm to them. And there is a lack of awareness of the output limiting features in their devices, where they can use it to limit the output of the device. Now, the European Commission has mandated that all devices, since I think 2013, all devices has an output limit, and this output limit can be overridden. Like the young adults, or anyone can override this feature and go up to the maximum of the device. And when we're talking about the maximum output of the device, we're talking around 107 decibels in some studies. They do listen to their, or young adults and adolescents are using their devices for up to 3 hours per day. And there is high prevalence of hearing loss among listeners. And also, we have the high risk and we have the good awareness. So studies are showing that there is the high risk for a number of adults, but also other studies are showing that we have good awareness. Studies also are showing poor knowledge. Again, we're talking about the knowledge in young adults. A recent study of Apple devices showed that around 10% of 20,000 participants, 200,000 participants exceeded the World Health Organization limit that mandates that, or that recommends that it should be around 80 decibels. Also, 2/3 of the respondents are using their devices at a safe limit, whereas there is this 1/3 that are occasionally using their devices at maximum limits. The effect of education is quite important when we are talking about young adults. So this study has shown that around 8% of the participants considered hearing loss to be a significant issue. However, when they did a follow-up study with proper education, they found that this percentage has increased to 30%. So this highlights the importance of education. And there are some good practices that is reported by young adults. So basically, these studies are collectively emphasizing the widespread use of the personal listening devices, the associated hearing loss, and the need for increase in the awareness of safe listening practices. So the study is aimed to investigate the usage of personal listening devices among young adults, their knowledge about noise-induced hearing loss, and the prevention methods through hearing protectors. So the method, it was a survey study. We looked at 274 participants, and we attempted to calculate the noise exposure based on their responses. In regard to the findings, the noise exposure, 1/3 of the participants in this study were exposed to very high noise levels from their personal listening devices. And this has been linked to the hobbies they were performing. Half of the participants could not recall if they had any formal hearing evaluation. So this suggests the need to mandate regular hearing checks for adults. and this has been mentioned in the previous talks today. 35% of the respondents reported that they had transient tinnitus. 2.4% of them reported persistent tinnitus. As for the hearing difficulties and self-reported threshold shift, around 30%, which is also a third of the participants, reported experiencing some hearing threshold deterioration at some point in their lives. There was an evident knowledge and practice gap where the majority of the participants said that they had high knowledge about the hearing protectors, but when asked how often do you use hearing protectors, a very small number reported that they were using hearing protectors. As for the information resources, with the advanced technology, most of the young adults are taking their information from social media, and these channels should be utilized for campaigns to increase the awareness about harmful listening habits. So adults do face the risk of hearing loss from unsafe listening habits. They show a gap between the knowledge and their practice, and there is a need to increase the awareness of hearing loss protection and, most importantly, the annual hearing evaluation. Thank you very much, and I would like to invite you to the Arab Hearing Health Conference that will be held in Jordan in April, and this is an annual conference. Thank you very much.
Thanks, Dr. Hala. Now, Dr. Farid is here.
Good morning. Yes. حطيته فين؟ First. Thank you for having me here. I will present you the hearing screening among school age children, a study which was conducted in a town in Algeria. So for the time, I will don't repeat what already said. In epidemiology, we have already done a study on neonatal hearing screening. We have prevalence of 3.2 per mil, and we aim to study after that what is the prevalence. So we conduct this study. So the objective was to identify the risk factors and to identify the prevalence among school children. The duration is 24 months. It is a prospective randomized cross-section study. So it was conducted in school children. So we use we use this type of study for the purpose of this study. So among 64 schools with 30,000 children, we get 43 classrooms with 1,480 80 children. So for the first step of the study, we do auto emission, acoustic emission, and otoscopy. For the second is the same, and we diminish the number of patients. And the third step was to identify etiology of this hearing loss. So for the result, we have 1,480 infants. This is the materials used for this, and the results. Parts of abnormalities, absence of PINA, or in imaging malformation was found. So on the result, there is no statistically significant result on sex. We find meningitis, seizure. One patient was having hearing loss after anti-lymphoma chemotherapy, had injury. This is the result for the 1,400. But we focus on the results on the 27% of hearing loss found on the study. So the risk factors of joint committee for the APGAR, there was children without hearing loss presented with APGAR -5, but in the children with hearing loss, we have found example 7. So on, we have the result on the different risk factors. So we found significant association between allergic rhinitis and polyp and otitis media with effusion. No statistically significant correlation between otitis media and the gender. So the result, definitive result, was for the first stage, we found 27% of children having hearing loss, but after treatment of the different acute pathology, we found 11% of hearing loss among children. So the characteristic of this hearing loss, for the first stage was the majority was having conductive hearing loss. The sensory neural hearing loss was 30, so 2.1%. By age, the age, the hearing loss rise with age, like in the literature. So this is the summarizing of the study. So on the discussion, we found similar results in the literature. We have for the materials used, otoscopy, autoacoustic emission, pure tone audiometry, and ABR. So the cohort size, we have already done this a study for neonatal hearing loss For Algeria, with a cohort size of 15,000, and for this it was 1,480. The age of the children examined between 4 and 15 years, and the distance by gender is not significant. One. The success ratio is 1. The threshold of difference in literature, it is very disparate. With our distribution was on the slide: moderate, severe, and kyphosis. The prevalence of deafness in the literature, neonatal hearing loss was 3.2 per mil in Algeria, and for the children between 4 and 15, it rises to 10 to 11% for this study. The degree of deafness, the majority was mild to moderate, and require only hearing aid. The type of deafness, sensory neural hearing loss was 7.5% of all the hearing loss. Cause of deafness, occurred hearing loss was 92% on literature, and the cause of deafness where we find ear wax, plug, and otitis media was the most common causes. So, on conclusion, child deafness represents a public health problem due to its catastrophic consequence for child's psychomotor and education development. Early detection of deafness in children allows for early intervention and rehabilitation. We found a prevalence of 27% of children with auditory pathology at the first stage. After treatment, we are to 11% require long-term follow-up. This show that after neonatal hearing screening, it is mandatory to continue to screen ages. Thank you.
Thanks, Dr. Farid. Now, Dr. Suela.
Good morning, everyone. I'm Professor Sallavaci. I'm coming from Albania. I work in University Hospital Center Mother Teresa of Tirana. Please go to Suela. Thank you. Thank you very much. And the location of Albania, as you know, is north of Greece, south of Montenegro, and is a land area of 28,748 kilometers square, and a population on January 2021, it was around 3 million. And urban population was 62%. These are some pictures from my city where I was born and I decided to live. and work, Tirana, please come and visit us. You'll be very happy and you'll return for sure. This is my hospital, and this is the place where I work. In order to avoid to spend a lot of words, because all the colleagues here said some words on this hearing screening and all the problems of hearing loss, I'm just passing the theoretical part, because in this roundtable we are discussing about the hearing screening on genetic problems. But we have other problems even in newborn hearing screening, which I will mention later. Okay, a screening program can be either universal or targeted, and in around a population of almost 3 million of children, almost 29,000 children are born every year. From them, 1 of the 4 are born in Tirana, capital city. In Albania, universal neonatal screening for hearing loss is still not established by law. But we have done a lot of screening programs because we never stop fighting. And until now, all the screening new programs has been carried out in the several public maternity hospitals, but they are exclusively financed by donors or respective projects funders. And these initiatives has been sporadic, not continuous, and not on a regular basis. These are some study on prevalence of hearing loss that I made it, and 1 or 2 of my colleagues. The first one from 1999 to 2015 with the children of Institute of Children who does not hear, and 423 children were treated and doing all the ear implants, cochlear implants, hearing aids, and speech therapy, of course. During the period 2003 and 2006, 16,400 children were screened in the primary schools. It was really a mass screening prevalence study. From that time, we had 4 children in 1,000 births with hearing loss, neurosensory hearing loss. Another screening of children of 4 to 6 years old in the kindergartens, it was made on 2004-2007. The prevalence in Albanian children at that time of the hearing loss, I mean neurosensory hearing loss, was 2.8 for 1,000 births. On 2004-2008, we did a neonatal screening of neonatal intensive care unit on 2 maternities in Tirana, and all the children that went there and needed a special, they have special needs, were screened. Universal neonatal screening of all children in maternity hospitals in Tirana, Fier, and Shkodër, which are cities of Albania, was done on 2009 and 2012. In that period, 40,341 children were screened. The prevalence, it was 2.1 per 1,000 births. Screening on otitis media, what was a massive screening on otitis media, which included Balkan and Baltic countries. This study was also published in a very serious journal, and it was done within 2 months, May to April 2019. In that time, I examined 529 from 500, which was decided for our population, but we have a prevalence of otitis media was 23%, which comparing to other studies was a little bit high. Also, in a full 2 years, 2018-2019, all the newborns were screened, and the prevalence of hearing impairment is being calculated, no data for the time being, because it's just in the processing of publishing and doing, and all the donors needs their own authorization for that thing. Finally, after doing a lot of job on that direction, I've studied in different universities in Europe and in States, and with a very good team of my hospital, we just doing everything that you cannot imagine every day in order to establish by law the hearing screening to all the children, to all Albanian children. We are a very small country. You cannot imagine how rich we are. But the mentality is to steal everything. We change ministers every 6 months. So finally, on 2019, the Albanian government approved the start of the implementation of the deafness treatment program for Albanian children. By that time, 20 children per year will be helped with cochlear implants, with the fully technical and medical assistance of MEDEL. Sorry for this thing, but I have to mention that 30 children were implanted so far. But this didn't start in the time. In the private hospitals, we started cochlear implantation in 2007. But in the public hospital, in order to profit everyone, we started on 2021 because of the pandemic. We postponed a little bit the interventions. As I mentioned, the first 5 cases were operated in 2008. Then on 2013, other 5 cases in the hospital, in a public hospital. But after 2019, we have now the possibility to treat the hearing loss. We made a study on the, I don't stop on that, but I go directly to the results. The study aims to assess the hearing acquisition among patients undergoing cochlear implantation and the improvement in perceptual and communicative skills. Of course, that all patients underwent in-depth examination, as you can see. We work as a team, and we decide as a team who to include, how to include. We do interviews, very deep interviews with the families, which you know they are very important on that. And we have 28 patients, young patients, and 7 adult patients which have been in years our patients. Total participants, as a children, 28. Mean age is 6.81, which is a little bit high because of the absence of the hearing screening. And as you see, the maximum age is 22. I will pass the results as graphics, and I come to some conclusions. Almost all implanted children, because we wanted to one more testify to our government, which are the results of discovering as early as possible the hearing loss in order to have then not handicap problems, but to have to give the possibilities to everyone, but to have the children and all the generation in a good conditions. So almost all implanted children have benefited significantly in terms of hearing. Only in one child we still do not see a reaction because it was not taught by the parents to keep the implant all day. Most children benefited also from speech therapy, and you see 5.3 satisfactory, 15% very good, according to our protocols of speech therapy. The children who benefited the most in the terms of hearing and significant improvement of perception and communication were those, in addition to cochlear implantation, underwent speech therapy education and continue to wear a hearing aid in the other ear. This proves once again the importance of binaural prosthesis or implantation. But we have still a lot of challenges to be addressed. The Albanian government is still not creating the law for universal neonatal screening. The budget dedicated to health is only 4% of the annual budget. Patients who suffer from hearing pathology are given an economic aid, which is insufficient to provide acoustic prosthesis or cochlear implants and speech therapy education. Also, the problem of lack of sustainability of initiated programs and interventions is evident. After the financing period is over, the respective screening programs have discontinued. There is not even one exception on that. Therefore, there is need to plan future interventions together with Ministry of Health and the approval of the ministry that it will support the program. If it turns out to be cost effective, must be obtained beforehand. Despite the great and continuous information efforts, we still notice that a good part of the health personnel are not sufficiently educated about this problem and still do not understand the importance of early diagnosis of hearing impairment. Albanian families find it difficult to accept that their child suffers from a handicap. This is the main reason that we lose children diagnosed in the second and third stages of screening or at the moment when acoustic prosthesis or cochlear implant is proposed. Some of them do not appear at the scheduled appointments. As a final consideration, over the years, we see that we have from 3 to 4 children per 1,000 to 2 children per 1,000, which is a better prevalence on hearing loss. Also, during all these years, we have organized various conferences, workshops with pediatricians, family doctors, otolaryngologists, and we still continue to organize sensitization campaigns in media in order to sensitize Albanian families so they can turn to doctors as soon as possible after realizing that their children may have certain problems with hearing. Likewise, we have organized several meetings, we have prepared memorandums and written projects addressed to the Ministry of Health to make it possible to sensitize them in order to legally approve universal newborn screening. Also, we have worked seamlessly in all directions based on some 2021 World Health Organization guidelines regarding hearing problems. We can recommend something. Development of a national database on deafness and hearing impairments, also developments of training resources in primary ear and hearing care centers for primary care workers. Developing and disseminating several guidelines against the major preventable causes of hearing loss, building partnerships, increasing awareness about the level and cost of hearing damage, and continued encouragement of the Albanian government to finally approve the universal neonatal screening of hypoacusis. And thank you very much.
Thank you, Professor Suela. Thank you. I will not speak much because all my colleagues said all we can say about the neonatal hearing screening, but I want to present the Egyptian Eman Ghorab round table, please. The Egyptian experience. I am honored to be one of the presidential committee for early detection of hearing loss in the neonates, and I am the scientific consultant of the initiative for the or the program for the neonatal hearing screening in Egypt. So I will present our results up till now. I will not speak too much because time is running out, but for the initiative, it started several trials in the early years before 2019, but since 2019, it started to be an important point for the Ministry of Health, and the national program started in 2019. Of course, many challenges faced us in the program, but I think now it is much better than before. Of course, goals of us, like goals of all of you, is every child receives the timely intervention and the rehabilitation and increase awareness of the parents and all the community about the hearing loss. Our screening protocol is 2 stages screening protocol. 2 stages. First stage is using since birth in the first week after birth, and it is done in the primary health care units. In Egypt, we have 5,000 primary health care units all over the country. So we do screening in these primary health care units. We prepared up till now about 3,800 or more from the primary health care unit distributed all over the country. We do two-stage screening. First stage within 1 week, and if he fails the first screening, within the first month he do the second screening, and if fail, is referred to the hospital. Our program is universal for all population. It's much difficult in Egypt than in any other country because we have about 2 million births per year. So it is very difficult and distributed all over the country. Why in primary health care? Because it provides the postnatal services, and we short distance for all the patients or all the parents to go for the screening, and they are taking their vaccination and examination for thyroid function during this period in the primary health care unit. Before, this is the number when we started. This is the number of, it's not appearing why. The first stage, we started by smaller number and now reached more than 3,500. No, it is, this is older. Now it is 3,800 units now working with the screen. Of course, we have, so many governorates in Egypt. So in each governorate, we see the number of live births there and number of centers, and we increase the number according to the number need screening in this area. Of course, many obstacles. I will not speak about obstacles now. We started to manage, and this is the progress in the attendance of screen. At first, when we started, the screening number was 55% of all live births. Now our screening program reached to 38% of all the neonates are screened in the primary health care unit, which is considered a good progress in our program. Our main problem was the second stage screening, loss to follow up, like Dr. Ebtessam said before, and this was main obstacle for us. Now we reached to only 9.34% loss to follow up, because there is now a center in the Ministry of Health which follow up all these neonates who didn't attend the second screening and follow up to do the second screening. In each governorate, there is a center to follow these patients. So the number of loss of follow-up decreased much. Of course, red flags, we ask the primary health care centers to announce if they have any problem of this problem. Even if they pass screening, they have to do follow-up. Diagnostic stage is done in the tertiary hospitals. We prepared 34 well-equipped hospitals up till now, and we are now planning to prepare more 10 hospitals, and besides the university hospital, of course, for the diagnosis of the neonates. Again, the problem is not only the screening and diagnosis, the data management. If we have to screen baby in the neonate or remote area, how can we follow, and how can we follow the results of screening, and where to go after screening, and how to do diagnosis. So that a system was planned and done with the Ministry of Health to enter all the data of the child since the reaching the primary health care center, and after that the results are put in the birth certificate, and if he have failed screening, he take card like this card to go to hospital, and his information is sent directly to the hospital to follow him, and when he reaches the hospital, he find all his informations and even if there is a risk factor, and after that, the data of the hospital, after the results, is sent to Ministry of Health for the analysis of the result. We reached now 7,288,000 number screened, which is a good number. Of course, 66 screened from the beginning of the initiative, but now it is 83 in this year, till November, 10 November. Of course, not all the number referred to the hospital reach the hospital, because still we have many patients are refusing the governmental hospital, and they seek medication and follow up in the private sector. So referred number was 48,000 and reached 31,000 only, but we had normal from them 35.5%, and hearing aids were done for 838, and the cases who didn't give good results with the hearing aid, we go to early cochlear implantation for better results, and more than 2,000 now undergone cochlear implantation. So at the end, hearing loss can be avoided through public health strategies and the clinical intervention implemented across the life course from prenatal, natal period, and in older age. And each country must develop its screening protocol based on several factors such as nature, severity, of hearing loss, to be identified, screening tool available, and of course, financial availability of this country. Thank you. I think by this we come to the end of our round table. If anyone has any question, we are ready. And if there is no questions, now it is time for coffee break.